Hi. So we are talking about chapter 8, which is periodontitis and other periodontal conditions. Last week we talked about the gingival conditions, and today it is periodontitis. So we know that gingivitis is a part of the periodontal disease process, and it is the only reversible part of the disease process. But periodontitis can affect children as well as adults. Okay, loss of attachment, the connective tissue attachment loss with subsequent alveolar and supporting bone destruction. That's the definition: connective tissue attachment loss with subsequent alveolar and supporting bone destruction. Another way of saying it is apical migration of the junctional epithelium. They both mean the same thing. You need to be able to identify that both mean the same thing, because on exams and your board exams, we don't know what language is going to be used specifically. Periodontitis can be chronic. There's also aggressive forms of periodontitis, and it's not based on age, but on clinical and radiographic findings. Now, this is very different from when I was a student. It was based on age. We had juvenile acute periodontitis, okay, juvenile. So that was for the younger people, but now we know it's not based on age. As science furthers our knowledge, things change on how we label things and how we treat things. So dental hygiene is, aside from cleaning the teeth, that part really hasn't changed, but the understanding of the disease process has, and how we treat the disease has changed dramatically since I was a student. So we know that the inflammatory immune response kicks in because of the biofilm. Okay, there are events occurring in the periodontal tissues. So there are microscopic changes in the lamina propria and epithelium. Now, what is the lamina propria? What's another name for that?
Connective tissue.
Connective tissue, correct. And those events initiate the development of periodontal disease. It sets up the body with the inflammatory response. So the histopathogenesis of periodontitis. We have Page and Schroeder lesions. Now, these are outdated. It was 1976, but guess what? Your board exam still uses this model. So you have to know it. This is where a lot of the science first came in. I started dental hygiene school in 1979, really. But so you can see that this was the latest science back then. You'll see Page and Schroeder. Sometimes you'll see just Page in research. Sometimes you'll see just Schroeder. And sometimes you'll see Schroeder and Page. So it all depends on who the lead researcher is, as far as whose name is on it. But these are famous researchers. They used animal models with some adolescent species or specimens, right? And a lot of this were beagles. And although these animal specimens were used in periodontal literature, it's not really considered up to date. But everybody, you're still going to see the Page and Schroeder model. Okay, so you have to know them. We've gone over this before. Initial, early, established, and advanced. Initial, are there any clinical signs for initial? This was last week, and the answer is no. All right, this is where you have some vasodilation happening in the connective tissue. That vasodilation allows more gingival crevicular fluid to seep into the sulcular area to bring PMNs and other immune response systems because those cytokines have already started talking to each other. Then we've got our early lesion, which is gingivitis, established and advanced. And we have everything right here in a chart. So this is everything you need to know. So the initial lesion, days 2 to 4, is subclinical. The early lesion is T cells. You've got your first signs of gingivitis. Then you have your established, which is B cell. You're going to get into more of the T cell, B cell with your pathology. Established is chronic gingivitis, and then your advanced is alveolar bone loss. So early is subclinical, initial is subclinical, early and established or gingivitis, and advanced is periodontitis. So your healthy gingiva, okay, you've got little supragingival plaque or biofilm accumulation, a few defense cells because they're always floating around looking, they're always searching for signs of invasion. It's PMN motivated, okay? And they migrate through that junctional epithelium into the gingival crevice and out into the oral cavity. So they are always circulating. Do PMNs, these neutrophils, do they live very long?
No.
No, they don't. They don't live hardly at all. So if you are immune compromised, that's why it's so important to know a good medical history, because those PMNs, which are the first line of defense, if they are not functioning properly, the entire bodily system is at risk for infection. Healthy gingiva. All right, everything's intact. Then you have your, you've got your initial lesion, which is the first 2 to 4 days. You've got your vasodilation. It's the beginning of gingivitis, but it's subclinical. You can't see it. There might be some bleeding on probing. Is the bleeding on probing, is it, does it just kind of spurt out, or is it seepage so that you're flossing and you're like 2 teeth away and then you're starting to see a little bit bleeding? When you're in perio, working in a perio office, you are quantifying and qualifying all of this. Because if you go in with the probe and it immediately bleeds, that means something very different than if you're 2 teeth away. So we've got the initial lesion, it's subclinical. Then we have the early lesion, days 4 to 7. It's the same features as the initial lesion, but you've got your T lymphocytes that begin to migrate into the tissue. There's about 60 to 70% collagen destruction. The early lesion is considered acute. You have to have acute before you get chronic. So it's an acute lesion. Early is acute with 60 to 70% collagen destruction. It's gingivitis. The established lesion, you're getting more of the inflammatory response going on. Your PMNs, your macrophages, which last longer than the PMNs, antibody producing plasma cells, those are your B lymphocytes. There's more collagen destruction. The bulk of the biofilm, the plaque bacteria cells, cause the junctional epithelium to detach from the tooth. The established lesion, you're starting to affect that junctional epithelium attachment. But it's not apically migrating. That's the difference. It's just loosening up. So you've got pocket epithelium that's mostly derived from the junctional epithelium with the formation of epithelial ridges and micro ulcerations. So with the established lesion, histologically, you're seeing the effects of lesions histologically. So it's gingivitis, it's chronic gingivitis, and it's still reversible. So these are those ridges that they're talking about, all right? They're in ulcerations. You're going to get bleeding on probing. The advanced lesion is periodontitis. Okay, there is clinical attachment loss with the loss of clinical connective tissue attachment to the tooth. There's apical migration of the junctional epithelium. Alveolar and supporting bone is destroyed. So it's the advanced lesion that's periodontitis. Everything else is gingivitis. So we have the inflammatory immune response. It's continuing. The periodontal pocket gets deeper as that pocket epithelium distends literally as well as apically. It's distending laterally, because remember how that biofilm cascades down? It starts super gingivally and then it starts migrating apically. So you need to have room for all of that biofilm and bacterial plaque, so the gingiva moves away from the tooth surface to allow more room. And that's where that pocket epithelium distends laterally. It's getting very flabby. The advanced lesion has all the features of the established lesion, okay, but the established, remember, doesn't have any apical migration. But it's got the alveolar and supporting bone loss. It's got loss of connective tissue attachment. And this is a B cell. Okay, plasma cells are B cell versus T cell. So is the established lesion, does that have apical migration?
No.
No. Yes, correct. The periodontitis is the advanced lesion. So you've got your initial lesion, which is subclinical. Your early lesion and your established lesion are gingivitis. And then the advanced lesion is periodontitis. Let me go back. Again, this has everything you need to know about that. Page 118. So flag that. So what's the sequence of events for pocket formation? Okay, so what is a pocket? A pocket is a pathologically deepened gingival sulcus. The sulcus is when it's healthy. A pocket is when it's not healthy, occurring between the root surface and the gingiva. So the junctional epithelium, we're talking pocket formation, is transformed into pocket epithelium with the development of those micro ulcerations and the epithelial ridges that normally aren't there. All right, so we've got a picture here. Okay, we're going to see healthy, then gingivitis, and super bony pocket. So healthy has no ridges. Okay, you're probing, everything's within normal limits. You've got the CEJ, probe is right below the CEJ, at or below. Gingival pocket, look at how the gingival pocket, the inflammation here is making the pocket, okay, appear. You're going to be probing deeper, but there's nothing affected. The attachment is still the same. So this might probe 2 or 3 millimeters, and you might probe 4 or 5 here. 4 or 5 is considered a pocket. Well, is it really? It might be what we call the pseudo pocket. There's no attachment loss. Reducing the inflammation will shrink that tissue down to that healthy 3. You have a suprabony pocket. The attachment is here. The bone is above. I'm sorry, the junctional epithelium is above the bone. Suprabony, but you have attachment loss, apical migration of that junctional epithelium. Gingival margin is about the same as it is up here, but you're probing deeper. This could be a 5 millimeter for suprabony pocket, or a gingival pocket could be a 5 millimeter. That's why we want radiographs. Where is the bone? Okay, that's what we're looking at. Where is the bone? So this is a suprabony pocket. The pocket is still above the bone. And then you have an infrabony pocket. The pocket is below that alveolar bone crest. Again, the gingival margin is about the same. You need radiographs to be able to see what's going on. And good radiographs. So for the periodontal pocket, the inflammation spreads from the coronal lamina propria subjacent to the junctional epithelium into the body of the connective tissue. So you're getting these inflammatory infiltrates. It increases in number of the inflammatory cells and decreases in the amount of collagen. Remember that those lesions that are 50% collagen loss, 40 to 50% collagen loss, it's being replaced with inflammatory cells. Those gingival fibers, which are collagen, are destroyed, followed by the apical and lateral migration of that junctional epithelium. So anytime you see apical migration of the junctional epithelium, you have attachment loss and you have periodontitis, not gingivitis. Is this making sense? So as the epithelium is detached from the root surface and the apical portion migrates apically, a pocket is formed. So a pocket refers to the soft tissue and not the bone. A pocket is referred to as attachment loss. Then we're talking about infrabony or suprabony. We're getting more specific. So if you have a pocket, periodontal pocket, you have attachment loss versus a gingival pocket. You don't have attachment loss, you just have an unhealthy sulcus. Periodontal pocket, you have destruction of the gingival fibers and there's apical migration of that junctional epithelium and there is bone loss. Another chart to flag, table 8-2. Everything you need to know. And look at this infrabony pocket. Okay, we looked at those, but there's also vertical or angular, okay, this means the same thing, bone loss that you're seeing on the radiograph versus suprabony pocket is always horizontal, radiographically. And you've looked at those in DNH 130. You've looked at them. So with periodontal pockets, we have an increased depth of the periodontal pocket that makes the area ideal for bacterial growth. It's dark, warm, moist, wet. You've got your gingival crevicular fluid feeding the bacteria anything it needs. It's undisturbed. And these bacteria communicate with each other and say, hey, come on, let's have a party. The folks are gone. Nobody will catch us. So you've got two types of periodontal pockets depending on the pattern of bone loss. Again, you need radiographs for this. Suprabony and infrabony. Suprabony is only what type of bone loss?
Horizontal.
Horizontal, yes. And infrabony is vertical or angular. So you've got this apical migration of that junctional epithelium. So you have cementum that's now being exposed. That surface is rough because that rough surface used to have ligaments attached to it. So the ligaments then are destroyed. So you've got this rough root surface where those fibers used to attach, and those areas easily absorbs those endotoxins and bacteria and their bacterial byproducts. Because the bacteria is releasing toxins. Those bacteria are communicating through cytokines and endotoxins to each other. They're pooping on the root surface, so to speak, after they metabolize waste and they have a waste product. And that then cementum is called necrotic cementum. It can get very leathery feeling. It feels very different. So the inflammatory process causes bone destruction, fibroclast, osteoclasts. And as the inflammatory infiltrate destroys and replaces more of that collagen in the lamina propria, so that inflammatory infiltrate is replacing the collagen, the alveolar crest is then compromised. So you've got your PMNs that release prostaglandins. You need to know prostaglandin E2. That is the specific one in periodontitis that destroys bone. Prostaglandins can activate resting osteoclasts, which destroy bone. Those osteoclasts are just sitting there waiting to be woken up and used. So those prostaglandins wake up those osteoclasts, and then the prostaglandins are also produced in the bone and have a direct effect on the bone. You have endotoxins that destroy bone. Those endotoxins are released by gram-negative bacteria. Does healthy biofilm have gram-negative bacteria in it? No. These are the pathogens. And we have B cells. Remember, it starts with the T cell and then goes to the B cell. So the B cells are more advanced. These osteoclasts, okay, need to be in our system because they take care of dying bone. What happens when a patient's on bisphosphonate or other osteoporosis fighting bacteria is it inactivates the osteoclasts, so the body doesn't have a way to absorb the bone cells that are dying. And every cell has a living cycle to it, a life cycle. You're going to die, okay? Each cell is going to die and the body takes care of it. But when you're on bisphosphonates especially, the body can't absorb those dead the dead bones, so you end up with that with other infections, bone infections going on. So we've got bone destructions, and cytokines destroy bone. So we've got the prostaglandin E2 that's waking up, okay, the osteoclast. We have cytokines that are released from the macrophages. We have interleukin-1. Remember, that's if there is an interleukin-1 genotype as well. 30% of the population has an interleukin-1 genotype. It's just in our genes. That means we are more prone to be able to, okay, have these cytokines. The interleukin-1 also stimulates the prostaglandin E2. So it's a no-win situation. It's a cycle. The philosophy is these are very site specific. Because you can have healthy, then boom, a pocket. Healthy, boom, a pocket. All right, site specific. It's not generalized. So that's why when we're doing a periodontal assessment, we want you to be as accurate as possible in your description with your AAP and ADA classification. We've got your generalized this and your localized that. It's not just one classification. We want to know, okay, it's generalized, 30% or more than 30% is going to be this. Localized, it's going to be that. And then when it's localized, we're going to state where. Is it the mandibular anterior? Is it the maxillary left molars? Where is it? So it can be site specific, but pocket formation and bone destruction does not occur in all the areas of the mouth at the same time. And we really don't know why. But we do know that the pathogens from one pocket site can be transferred to another site that doesn't have a pocket. And if the immune response is compromised, that bacteria is going to take over because it doesn't have the disease fighting capability. So the degree of bone loss is not necessarily correlated with the depth of the pocket. Where is the gingiva in relation to the pocket? We need radiographs to determine the extent of bone loss. Especially, are they a perio, let's say a 1 gingivitis or early periodontitis, or are they a 2, which is more moderate? Are they, it's if you're in between early and moderate or moderate and advanced, it's a judgment call and you really need those radiographs. Advanced, you pretty much can just look at the radiograph and walking by going, oy vey. But if it's in between, you need to really look. So a patient may have had surgery, let's say, and the pockets were reduced, but the bone levels remain the same. So you've had bone loss. They've had periodontal surgery, so they've had a facelift of the gingiva, so to speak. So they recontoured that gingiva to be closer to the bone. You have exposed root surfaces everywhere, but your probe readings are 323, 323, 323, 212, 212, 212. Sounds healthy. Sounds perfect. So the patient might not currently have severe periodontitis, even though the radiographs show severe bone loss. So that's where these new classifications that you're learning about, this AAP that everybody's still so confused about because it's new, where we are classifying this, okay, the radiographs. What type of gingiva is on top of that bone? You can have a periodontal stable patient that's had surgery or not surgery, but their gum tissues are beautifully intact. There's no bleeding. They're completely healthy, but it's on a reduced periodontium. Or they could be a complete mess. So we're describing that. We're describing the patterns of bone loss because the pattern of loss can depend on the route or route of the inflammatory infiltrate. So you've got your gingiva, okay, that is inflamed. Then you've got your bone being affected and your periodontal ligaments, your principal fibers are being affected. It all starts that destructive process. There's 2 patterns of bone loss, horizontal and vertical. You need radiographs to determine that. So horizontal bone loss is your suprabony pocket. The deepest portion of the pocket is located coronal to the alveolar crest. Suprabony. Horizontal, suprabony. Horizontal, suprabony. Bone resorption occurs from the outermost aspect. You don't need to memorize this. Infection wants to go to the easiest place it can destroy. So it's finding susceptibility. suprabony, infrabony. So the inflammatory infiltrate spreads from the gingiva through the connective tissue into the bone, following the most vascular pathway. Okay, because that's where the blood vessels are located. Sometimes the most vascular is on the side of the alveolar crest, allowing that inflammation to directly enter the periodontal ligament, and sometimes it's on the facial. Okay, so you don't know what that pattern of bone loss is going to be. The body is seeking it out. Horizontal bone loss. I'm probing 6 millimeters, 8 millimeters, whatever. Okay, I don't know if it's supra-bony or infrabony without looking at the radiographs. Horizontal bone loss is always supra-bony. Versus vertical or angular bone loss. They both mean the same thing. The inflammation travels directly from the gingiva into the periodontal ligament. That interproximal bone level is not flat like it is seen in horizontal bone loss. And the bone loss is more rapid on one side of the tooth than the other. So for vertical bone loss, the base of the deepest portion of the bony defect is apical to the alveolar crest, creating the infrabony defect. And I hope seeing it in words is starting to make sense to you. All right, so you learned you connect two CEJs, right? CEJ to CEJ to determine if it's angular or horizontal bone loss. Okay, but look at this here. This is really considered angular bone loss, even though, doesn't that look like it would be horizontal? Do you remember what this is called?
Is that the fenestration?
Fenestration. Fenestration and dehiscence. Remember those terms. So vertical bone loss. You can see the vertical bone loss. The bone is here, and then the bone is here. Bone is here. Bone is there. Vertical bone loss versus horizontal. Sometimes you don't know, is it a root canal? Is it an endo lesion? What type of lesion is it? And this is really cool. This is a gutta percha point, which they use in root canal therapy to show the origin of an abscess. So the patient has an abscess that you can see on the outside. They've got a fistula. So what you do is you place one gutta percha point this way, and if they have a fistula, you place another gutta percha point into the fistula, and it will take you to where the origin of infection is. I used to do that with perio when I was working in perio. It was fun because we like poking things. But is it an endo lesion or a perio lesion? You don't know sometimes. And sometimes it's a combined lesion. So vertical bone loss is an infrabony. Horizontal bone loss is suprabony. Okay, so we're talking infrabony defects, and there's different types of infrabony defects. So we're getting more into the weeds here, and it's classified according to the number of osseous or bony walls surrounding the tooth on the interproximal. Is the bone loss mesial, distal, buccal, or lingual? How many walls are left around? So you have a 3-wall defect, a 2-wall defect. You've got these type of defects that are classified. So look at this 3-wall defect. A 3-wall defect, you have 3 bony walls remaining and 1 is missing. So if you've got 4 walls and you have a 3-wall defect, 1 is missing and 3 are remaining. And as a student, I didn't like this because to me, a 3-wall defect, intuitively, I was thinking, well, that means 3 walls are missing. Well, it's the opposite of that. 3-wall defect, you have 3 walls remaining. A 2-wall defect, you have 2 walls remaining and 2 walls are missing. You can also have a crater in a 2-wall defect to divide it even further. And that's a specific type of 2-wall defect where the buccal and lingual interproximally bony walls remain and the mesial and distal walls are destroyed. So a crater is literally a crater in between 2 teeth. And then you have a 1-wall defect where 1 bony wall remains and 3 walls are missing. So if you were going to have a bony defect, which type would you want? A 1-wall, 2-wall, 3-wall? What kind of bony defect would you want?
A 3-wall?
A 3-wall, exactly. I was going to say 4-wall, but then the tooth comes out. Okay, so a 3-wall bony defect is advanced. There's something called a hemiseptum defect, and that's where only 1 buccal or lingual wall remains. So it's holding on for dear life, this tooth. All right, so this is on page 124. All right, so you've got your 3-wall bony defect here because 1 wall is destroyed. Your 2-wall bony defect, okay, 2-wall, this is your crater in between 2 teeth, and your 1-wall bony defect. Nothing holding on that tooth because you only have 1 wall intact. So depending on the type of bony defect the patient is exhibiting will also depend on what type of surgery or treatment that tooth may respond to, because they have surgical treatments that can add bone. This is just another way of saying if with a 3-wall bony defect, you have 3 bony walls remaining. If the buccal and lingual walls remain and you only have destruction between 2 teeth, it's called a crater. 1 bony wall defect, okay, is a 1-wall defect, or a hemiseptum is the other term for it. I haven't seen the word hemiseptum in years and years and years. And we're back to that picture. Bony defect. And this, my friends, is why we don't like taking horizontal bite wings. It's okay for caries, but it is lousy for perio. Can't see the bone. And if the patient had restorations, if they had crown margins, you wouldn't even be able to see around the crown margin. So you can see the defect. Surgically, they can place bone or other things in there, close it up, and you're going to have chapters on this, and then the bone can fill in. 2-wall defect, if it's between 2 teeth, what's it called?
Hemi something?
Crater.
Is it crater?
It's a crater. If it's between 2 teeth, it's a crater. Okay, it's a crater, just like the gingiva would be cratered gingiva. Okay, it's not a papilla. Okay, if that papilla is all gone, it could be blunted, or if it's like this, it's a cratered. And then a one wall defect, there's only one wall still supporting the tooth. So bone destruction, okay, the process radiates from the plaque mass, that biofilm. The destruction radiates 1.5 to 2 millimeters beyond the mass. Right, so bone destruction only occurs outside that 2 millimeter. All right, so you have to have that biofilm plaque mass that is undisturbed so destruction can occur. So think about it. It wants those deep pockets, those warm, dark, moist, undisturbed areas. But the thickness and width of that interdental septum varies from area of the mouth. The wider the interdental septum, like on your posterior teeth, okay, is going to be more resistant than the narrow septum on the anterior teeth. The mandibular incisors have very thin to no cortical bone. So they are very susceptible to bone loss because they didn't have a lot of bone there to begin with. So that's why sometimes a doctor might recommend orthodontic treatment to straighten out the crowding on those mandibular anterior teeth to allow more bone destruction, or more bone to fill in, excuse me. Again, 2 millimeters. Different types of bone loss. How would you grade this Panorex? Is it a good one?
Bad.
No.
What should have been done with putting this patient in position?
Is the chin up too high, or like
the chin is up too high? Exactly. Now, looking at the bone loss, this is probably not a young individual. So that maybe is the best position that this patient could have been put in. I mean, we have to be generous with what we're looking at. This could have been the best that we could have gotten. For a textbook, this is not what I would have used. Okay, bone loss in the mandibular anteriors because the bone is so thin. Classification of periodontal diseases, page 126. These are the old classifications. And we've looked at some of this. Papillon, Lefebvre, Shediac, Higashi. They're classified just a little bit differently now, but you, I think, are going to be the last board questions that have both the 1999 classifications and the 2018 classifications. So that's why we are having you do both. So for periodontitis, when classifying the disease, we want to know extent. Is it localized? Less than 30%. Is it generalized? More than 30%. You can have both. If something's localized, I want to know what the generalized is as well. Generalized, blah, 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 with localized, blah, blah. Classifying the disease. Mild or slight, moderate or severe. Old classifications. Mild, moderate, severe. clinical attachment loss, not pockets. This is where students get confused. Well, I have 5mm, generalized 5mm pockets. It must be severe periodontitis. Got to look at the bones. What is the clinical attachment loss? We no longer have juvenile and adult periodontitis. They took that classification away. Now it's getting more specific. We're looking at the human body and the oral systemic link when we're classifying types of periodontitis and grading and staging. Chronic periodontitis is very common. It's slow rate of progression. It's directly related to the presence of oral biofilms. Okay, we've gone over all of that. 1999 classification. With pictures. So again, advanced, we don't need to see and guess when we see advanced. Now this is localized aggressive periodontitis. It is very specific with when you're looking at where the periodontitis is. It's premolars, it's the premolar, first molar, and anterior. Agrigobacter actinomyces, blah, 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 the AA, okay? They used to be called juvenile periodontitis because young teens would be getting this. You need radiographs. Then chronic periodontitis, what other factors are involved with them? Are they smoking? Do they have diabetes? Are there genetic situations going on? HIV infection, stress we've talked about, local factors. Is it tooth related? Is it occlusal discrepancies, food packing in, crowding, supraeruption? But we know that it is primarily a bacterial infection. P. gingivalis is the heavy hitter. When in doubt, this is the most common periodontal pathogen, P. gingivalis. Then you've got your Tannerella for synthesis and your E. corridans. Okay, but P. gingivalis, you need to know that. It's the garden variety pathogen that creates havoc. You've got your apical migration of that junctional epithelium. You want to see the root surface in relation to the bone level on a radiograph. Sometimes there's soft tissue recession that is visible or not visible. So if it's visible, you've got recession. If it's not visible, the gingival margin is at the normal place and you've got a deeper pocket. Aggressive periodontitis replaces the term early onset periodontitis. We used to call it JP. When I was in school, it was juvenile periodontitis, and it's rapidly aggressive periodontitis and pre-pubertal periodontitis, okay? All of them mean the same thing, but they took the age classification out because it's not limited to the younger population. You can be as old as 35 and have it. It's divided, aggressive is divided into generalized or localized. In specific parts. Now, when you're seeing spreading of the teeth, the patient might come in and say, I didn't used to have a space between these two teeth, and they're moving. You want to know what's going on. You can see the apical migration. of that junctional epithelium. Bone level. For the aggressive periodontitis, patients are usually systemically healthy, but there's something that is creating a rapid attachment loss and bone destruction. There seems to be a familial predisposition. There seems to be a familial predisposition. So, what is aggressive periodontitis? It may include one or all of these. Bacterial accumulation is not consistent with the severity of the destruction. So what does that say? It says that the patient's oral hygiene doesn't really look like it warrants the amount of bone loss or bone destruction that you're seeing. You have an elevated level of AA, those are the really bad guys. That AA is one of those red complex pathogens. You may have abnormal functioning phagocytes. Okay, something's going on with your immune system. There could be elevated levels of prostaglandin E2 as well as interleukin-1. Usually occurs around the age of puberty. Minimal biofilm accumulation. So that goes back to you're not seeing the grunge mouth that you'd expect to see with bone loss. There's high levels of serum antibodies. Okay, so the body's immune response is being activated. The body knows there's infection going on, but it's just not taking care of the situation. So you've got localized. You need to know this. For localized aggressive periodontitis, it's the first molar and incisors with interproximal attachment loss on at least 2 permanent teeth, one of which is a first molar. So think about that picture that we were seeing, that radiograph, you've seen it twice, of aggressive periodontitis. It was the premolar area and the first molar. Okay, so that's one of the criteria for localized. And no more than 2 teeth other than the first molars and incisors. So you've got your premolar, molar, and the incisors. That's localized. Generalized is just what it means. Generalized, it's more areas than that, but it's including 3 permanent teeth and not just those areas. What are the bugs? You've got your AA. Now look at this. You've got your P intermedia, Provotella intermedia. We're going to be getting into this particular pathogen and AA a little bit more. Your E. cordans. We've heard that before. That was part of your perio. Your Campylobacter and this other species here, these are the 2 that you need to know about, the top 2. AA and P. intermedia. P. intermedia is going to be associated with other things without the AA. Pregnancy gingivitis, for example. P. intermedia. What is the general pathogen that is part of just regular chronic periodontitis?
Like streptococcus.
Gingivalis.
Yes, P. gingivalis. But we're talking aggressive here. So there's malfunction of the phagocytosis and chemotaxis. So things are arriving late and they're not taking care of business. So there's defects in the PMNs or macrophages, okay, usually not both. It's seen in 70 to 80% of the patients with aggressive periodontitis, this malfunction. Something's going on with their immune system. Then you've got refractory periodontitis, and that's been taken away. Refractory is when I was a student was you had perio 1, 2, 3, and 4, and then refractory, which was worse than 4. Refractory is a type of periodontitis that patients are labeled as when conventional periodontal therapy and their oral hygiene isn't responding. That's refractory. So you can be at any stage of the disease process and be a refractory. Kind of like a medically compromised patient. You can be a pedo medically compromised or a geriatric medically compromised. You can be an early perio and be refractory because you can't get it under control, or you could be advanced in refractory where it just continues on. With refractory, you've got your high numbers of P. intermedia, you've got your Tannerella, okay, Bacteroides, you've got your Fusobacterium, and your P. gingivalis. Okay, P. gingivalis is your everyday guy, but you've got those other bugs in there as well. So when you have a patient that's not responding to therapy, you need to start digging deeper. Is it something systemic? Do I need to take some sort of a culture to find out what bugs are specifically going on with this pocket area? And then what can I do on my end to help treat? So again, refractory periodontitis can be applied to all forms of periodontitis. 30% of patients with refractory periodontitis are smokers. Again, nothing good comes from smoking. Endo-perio involvement, okay? You have things showing up on a radiograph. Look at the bone. Is it root canal, endo, or is it a combined lesion? Radiographs are needed. You can see the decay here and the infection. We don't know what's going on underneath this crown, but this crown has extensive bone loss. Then we've got our peri-implant disease. We've gone over this. Peri-implantitis, peri-mucositis. Now the new classifications have peri-implant disease as a separate classification. So that's important to know too. Okay. Peri-implantitis is inflammatory reactions to the gingiva and bone. So it's periodontitis of an implant. Versus peri-implant mucositis is like gingivitis around an implant. So we need radiographs. We need to know where those threads are. Is it mucositis, gingivitis around an implant, which is peri-implant mucositis, or is it peri-implantitis? This is what it looks like, okay? And this is why we're being very gentle when the bone is removed or the flap is done. You are not able to clean these threads. This is a failing implant. You don't want to scratch those threads. So that's why you've got other instruments that you're using. This patient needs to be sent to a periodontist if you're not working in the perio office, and then they need to decide what can be done here. Can this be flapped? Can this be sanitized? And can there be bone augmentation? Bone loss to the first thread is considered normal. So this is the neck of the tooth here, the neck of the root form. Bone loss to the first thread is considered normal. So that is anticipated when that implant is being placed. Then we've got our 2018 AAP staging and grading. And I'm going to be placing even more videos on Canvas, but you've got a couple videos explaining this and how to do it. We're going to hopefully, did you go over this in clinic with your patients when you were working on each other?
I don't remember it.
Okay, well, this is stuff that you need to print out then, as far as not this particular slide, but go onto Canvas and take a look. And because they've got some good cheat sheets, so to speak, to let you know what the AAP classification is, the new one, and the ADA classification. Ay, ay, ay. But this also is explained when you're filling out the template, okay, after you collect all your data for your perio assessment, then you go to the template and it's asking you this. We've included the classification and what it means. All right, so this is on Canvas here, and you can print this out, but the severity, you're going to do staging. This is radiographic bone loss. Interdental clinical attachment loss. Interdental, so it's not talking about facial recession. Interdental bone loss on a radiograph. Severity, complexity, extent, and distribution. Something very good to have printed out so you can look at it. But stage 1 in the new classification is periodontitis. Stage 1 in the ADA classification is gingivitis. So it gets quite confusing. So you need to know both. So periodontitis is an inflammatory disease, common in adults. It can be chronic and aggressive. What is the primary etiological factor? It's biofilm. Then what the new classification does, it takes into other contributory factors so you can stage them and grade them. What other factors are going on? Do they smoke? Are they diabetic? Right? That's going to put them at a greater risk for further breakdown. So the new classification is looking at the entire body system to classify perio and not just the mouth. We only were concentrating on the mouth before. So now we're using more of the disease model, similar to cancers. You've got grade stage 1, 2, 3, and 4 cancer, right? You've got stage 1, 2, 3, and 4 periodontitis as well. Grades A, B, C, okay? Grade A is better than a grade B. Right? So if you've got a grade B, you've got some chronic things going on. So that is more, the grades are the systemic issues. Let's get into a couple questions here. Which of the following feature best describes chronic periodontitis? Okay, so it's, it's not primarily in children. It can be any age. There's no connective tissue loss. That is gingivitis. Bone loss does not occur, is gingivitis. So the only answer could be D. Only answer. Which of the following forms of periodontitis is associated with chemotactic defects with PMNs or macrophages? Defects. Very good. Okay. Thank you, Jonathan. Which of the following types of pocket has its base located apical to the alveolar crest. Apical to the alveolar crest. D, infrabony. Superbony is what kind of pocket?
Horizontal.
Horizontal. Pseudo pocket, what kind of bone loss is in a pseudo pocket?
None.
Yay. None. Okay. Which of the following is characterized by localized vertical bone loss in the first premolars in a 13-year-old with little plaque accumulation? Again, ruling out, you know it's not chronic, puberty-associated gingivitis, there's bone loss, so that's not going to be it. We've never even talked about ulcerative periodontitis, so the only thing is localized aggressive, which used to be juvenile periodontitis. Okay, guys, are there any questions? Because we're going to take a short break. Whoops, excuse me. All right, let's take a short break. I've got, it's 10:30. Let's take a 5-minute break and we will come back.